topic is Dr. Uday PRakash. Sir is a senior most faculty known to everyone. So this topic is totally pre-placement and MI arthroplasty neglected and failed fracture neck of femur.
USB.
By Dr. Uday PRakash.
USB.
Sorry, I told his father's name. Like Prakash.
Thank you very much, Dr. Hari Prasad, for inviting me here. Nice to be here. I'll try and be really quick, finish before 10 minutes. So, neglected fracture neck of femur, the definition varies, but I've gone back a few decades and included Maya's definition, which is anything presenting 30 days and beyond, any fracture of neck of femur presenting 30 days and beyond. So the longer you wait, the radiological changes start appearing, and you can see on the right, the neck has resolved, and slowly the proximal femur starts to migrate up. A failed intercapsular fracture, I think what it means is you have treated the fracture and it has failed. So so I'm going to talk about THR and hemiarthroplasty in such fractures. I think there are two different procedures. Technique might look very similar to start with, the approach is similar, but there are two different procedures. So depending upon who you are, where you've trained, where you're working, you might choose to do one or the other. But sometimes THR may be the only option for you, particularly if the acetabulum has been eroded. If you look at studies, there have been no study up to date that has looked at these two procedures and compared them directly. So the current thoughts are that surgery is the mainstay of care. Whatever you do, surgery seems to be the answer for these people. Although there are many people who are out there in the community walking without any treatment, and especially young people, they seem to do reasonably well without any form of treatment for their neck of femur fracture. So as we've heard, young patients, I think it's not fair for you to do either hemiarthroplasty or THR unless you've given reconstruction a thought or even attempted it. And we've heard such a nice lecture by Dr. Pingley on how to do these, how to operate on these patients and what techniques to use. Older patient, I think either of these two procedures may work. Hemiarthroplasty, if done well, and I'm going to touch a little bit about what kind of implants we should be using. Of course, as I said before, local conditions kind of determine what technique you use. I think your training is paramount when you decide to do a THR, but hemi seems to be done by many people, particularly in our country. And there are different procedures. You can see on the right is a traditional Austin Moore. Although in India I don't see roughened stems, but they may be available. But Austin Moores are designed to be used in an uncemented fashion. I think the Thompson's people have used cement as well, but I often see Austin Moores being cemented, and that too very badly. So I think we need to be very careful about how we use prosthesis, what prosthesis to use, and what cementation techniques to use. So this is the kind of thing that I see very often here. It's a smooth stem and usually put in an uncemented fashion. So it's a non-modular bipolar, which doesn't restore any of the biomechanical aspects of a hip replacement. This is what Dr. KJ has been talking about, and I think this should be your standard, whether it's a locally made a modular implant or something that, from abroad. So in countries like India, Africa, I'm sure you see many more presentations which are late. It starts off with a non-union, later on migration of the proximal fragment, loss of offset and other biomechanics, and then the more difficult aspect when you come to technical aspects is release of all the capsular and other soft tissue contractures. And if you leave long enough, you may see AVN, although I'm quite surprised to see many neglected neck of femur fractures which do not seem to show an AVN. It's usually the neck that resolves. So I'm not going to touch on that. You've seen some wonderful pictures from Dr. Pingley. The over 60s, and don't take this number as a magic number. You can have, you can do arthroplasty in younger people, providing that their indication is correct. And with the current implants, with ceramic implants, with better polyethylenes, I think you can expect many decades of good service from these implants. So between these two, I think there are several studies that have looked at the outcomes of both, and almost all of them report that THA's total hip arthroplasty is better than Hemi in terms of function. There is a slightly higher dislocation rate, but in terms of function, the THR is better. Just a couple of examples. This was a biological treatment given to a young patient by Dr. Uday PRakash 25 years ago, and she seemed to do really well for a number of years, and of late she started coming back again because she started getting pain, and you can see why. And she clearly needed treatment, but here you've got to think, there's no way that you can do a hemiarthroplasty. THA is the only option, but you just cannot go without thinking, without planning this procedure. So I need to discuss a little bit about technical aspects. Approach, it depends on what you're familiar with, although I prefer the posterior approach for even primary treatment of intercapsular fractures. Dislocation of the head of the femur might be difficult. Your neck cut should be accurate. Soft tissue release is paramount. You must release completely around the capsule, the soft tissues, although you cannot take everything away, which will leave you with a bare trochanter. So acetabular preparation and implantation, if your acetabular component is done first, the femoral preparation and trialing is done next. You must be completely happy that you've reduced the hip and it's got a stable range of movement before you move on to the femoral stem. This is how it looks after implantation. The patient is doing extremely well. This is another type of failure that you see. Neck is completely gone. Patient is about 45. I decided to do a hemiarthroplasty here because the acetabulum is reasonably good, and we decided to do a THR here. So you can see the neck is completely resolved, and this is a highly cross-linked polyethylene and an uncemented total hip. This was another form of injustice to the patient. The surgeon initially did cannulated screws for a 30-year-old, which is absolutely fine. It failed, unfortunately. Then this was done, which is literally a crime because there's so many mistakes done here. It's a wrong kind of prosthesis to cement, a wrong cementation technique. The patient never walked after this procedure. So the walls were thin. We had to be extremely careful to go in and put an uncemented implant. It's 12 years down the line, and she's absolutely fine. Just the last example of something was done. We don't know what was done in a district area. A pin was used to fix an intercapsular fracture in a 30-year-old. Complete injustice. So this is what I'm saying. Do not do any harm to the patient. If you do not know what to do, refer the patient. Standard total hip replacement with all the technical considerations. Here she is. So do not say that the patients cannot sit after total hip replacements. Most patients should be able to sit after a total hip replacement on the floor. So it's an unsolved fracture, I think, as far as the anesthetist is concerned, because most of these patients are moribund or quite, have multiple comorbidities. I think you need to be pretty clear in your mind what you're going to do, especially with the elderly. So the local complications are many: dislocations, periprosthetic fractures, infections, and later on erosions of the acetabulum. You need to be aware of these things and then plan your surgery. Just a couple of papers: review of 500 hemiarthroplasties through an anterolateral approach. The higher risk of dislocation is in people with dementia and inability to restore the offsets, and that's what I'm trying to say. Make sure that you can restore the biomechanics. And this is through a posterior approach. Dislocation rate is slightly lower than the previous study, but the most important thing is if you go posteriorly, you must restore the soft tissues, capsular closure, and short external rotators. In fact, I tend to preserve the piriformis now, which gives me a better stability. So conclusion: in neglected fractures in young people, try and preserve the head. Older patients, you can do either hemi or a total hip. In failed internal fixation, again, if AVN or complete neck resorption, THR is the option, and otherwise cemented hemiarthroplasty should do the job. Thank you very much.